Good afternoon. As we begin, this is the Senate Judiciary and Public Safety Committee. And for the record, this is Tuesday, February 19th, 2019. And also for the record, we do have a quorum. Today's agenda is Senator Rosen's Senate File 751 on opiate epidemic response, as well as later Senate File 766, Senator Ingebrigtsen's bill on DWI modifications. Senator, you may approach the table. Looks like we have Senator Eaton as well. Welcome to the committee.
Thank you.
Senate File 751 received an extensive hearing with general testimony in the HHS committee, which is the Committee on Primary Jurisdiction. As a re-referral, the Judiciary Committee will take testimony only on matters specifically within the Judiciary Committee's jurisdiction. And at this point, I'll ask our research staff to tell us what that jurisdiction is on this bill. Counsel?
Mr. Chair and members of the committee, I'll go through this a little. Mr. Chair, members of the committee, can you hear me now? Okay. So I'll go through this a little bit slowly.
The audience says that they want to hear you louder.
Oh, okay. Okay, so I'll go through the pages and line numbers slowly, but please let me know if it's too quick. Page 4, lines 4.24 to 4.27. This authorizes the Board of Pharmacy to use sale and delivery data submitted by manufacturers, as well as other data that's already reported to the board through the prescription monitoring program, and to use that data to determine which manufacturers are required to pay an opiate product registration fee. Then page 12, lines 12.1 to 12.8 states that if Minnesota is a named party against an opiate drug manufacturer and receives a settlement of $20 million or greater, then certain fees must be reduced to $5,000. There's some additional language about those fees, but that's not necessarily within the jurisdiction of this committee. Page 16. Lines 16.22 to 16.29. Under current law, a person dispensing certain controlled substances must look at a purchaser's valid photo ID. This section requires a doctor of veterinary medicine to do the same. Pages 18 to 19 make a technical change, moving across cross-reference to Chapter 13, the chapter on data practices. Page 20, lines 20.5 to 20.12. These lines require a prescriber or their agent to view data already available to them through the prescription monitoring program before prescribing an initial prescription for opiates, and at least once every 3 months for a patient receiving an opiate treatment for chronic pain or getting treatment for an opioid addiction. Lines 20.13 to 20.31 on that same page provide exceptions to that mandatory data check. Those exceptions include a medical emergency, palliative care, and inpatient care, as well as several others. And those are, from the policy perspective, those are within our jurisdiction, and I think Mr. Turner has additional provisions.
Senator Dietzig?
Could you clarify, so is it 2013 to where? To the end of the page or to where?
Counsel?
Mr. Chair and Senator Dietzig, 20.5 to 20.12 provide language about when to have a mandatory check on the data, And then lines 20.13 to 20.31 provide exceptions to that mandatory requirement.
Ms. Turner.
Yes, Mr. Chairman and members, there are two public safety appropriations in the bill. On page 11, line 11.10, from the newly created opiate epidemic response account in the Special Revenue Fund, $384,000 is appropriated to the BCA for 3 new drug chemists, and then on top of that is $9,000 for supplies for a total of $384,000. And then the last page, page 25, there's $2 million each fiscal year for VSETs, Violent Crime Enforcement Teams, otherwise known as Gang and Drug Task Forces. And the Commissioner must place a priority on funding non-metro teams as part of the rider.
All right. Thank you, Ms. Turner.
Mr. Chair.
Senator Ingebrigtsen.
Thank you, Mr. Chair. On page, with the finances on page 11, Mr. Turner, what did you say they were for? There was 3 agents and what else?
Mr. Chairman, Senator
Mr. Turner.
Ingebrigtsen. They're not agents, they're drug scientists for the lab.
Okay. And that was it?
Yep.
Senator Ingebrigtsen.
Okay.
That's it under our jurisdiction.
Thank you.
All right. Sarah Rosen.
Thank you very much, Mr.
Perhaps you could just give a general review of the bill in general, but then focus in on the areas in our jurisdiction.
Absolutely. And thank you so much for this hearing, Mr. Chair and members. And fortunately and unfortunately, I have Senator Eaton here by my side. As you may recall, she did lose a daughter to the opioid epidemic. And we are seriously in an emergency here in this state. So this is our second year with this bill. The premise of the bill is to make everybody come to the table, including manufacturers, wholesalers, distributors, prescribers, treatment community, law enforcement, everybody that needs to be at the table, present and working on this jointly. So there is a increased licensing fee in the bill for manufacturers, depending on the units that are sold in Minnesota. The wholesalers and distributors also have a portion of increased licensing fee. Currently, right now, wholesalers, manufacturers, distributors only pay $235 to do business in Minnesota. So we are increasing it to generate $20 million. Half of that $20 million will be used by the Opioid Advisory Group to give to programs, treatment programs that are effective, evidence-based, that go through the results first type of criteria, which I think is very important. And then the other half of the money will go to the counties for their increased out-of-home placement costs, which we've seen skyrocket, of course, because of this epidemic and drug use in general. So I feel very strongly about that. The rest of the bill deals with some appropriations. As I said, and Mr. Turner mentioned, the $384,000 to the BCA drug agents or drug scientists. There are requirements on prescribing. That is very important because we need to get some consistency for the doctors. As you know, there's been doctor shopping. There has been an abuse with prescribing. So we're making sure that we have some guidelines there. Opioids are extremely addictive, but extremely important in the care for people with acute and chronic pain. So we are trying to get this right. And then, of course, we are requiring the use of the prescription monitoring program, which to date is very clunky and not used by everybody. But if a doctor prescriber is going to schedule drugs, Schedule 2 to 4, he is required to use the new prescription drug monitoring program. And that there are exceptions to that rule. And you mentioned several of those. I'll just mention them real briefly. Number one, if they're in hospice or palliative care, if they're being treated for pain due to cancer, if the dosage is 5 days or less with no refill, if the patient has an ongoing relationship with the provider, and that was a big consent on my part. If prescriptions issued within 14 days following surgery or 3 days of oral surgery. If the patient is admitted into the hospital, the doctor does not have to do the PMP. If it's lawfully administered by injection or ingestion, if it's due to a medical emergency, or if the system is down and it's not available. Those are the exceptions to the use of mandatory use of the PDMP. And Mr. Chair, if Senator Eaton would like to step in any time, I'd appreciate her having a chance to mention her thoughts on this. There's some continuing ed for our doctors on prescribing, and there is a very, very important piece, if I could go back to the mandatory use of the PDMP. It also says that, I have to find it in the bill, I'm sorry, Mr. Chair. It's very important, and it's, help me out here. I will get back to that, Mr. Chair, once I figure this out here. It's in here somewhere. Clinical, what we gave to the MMA. Professional clinical judgment. So the bill has changed in spots. So that is something that MMA supports, and if the doctor feels it's in his best judgment to increase the amount of prescriptions in his professional clinical judgment, that can be had. And I will find where that's at. Like I said, this has changed quite a bit since we've been to Senator Benson's committee, Senator Kiffmeyer's committee, and now you. And from here, it goes to Senator Abler's committee, to Rules Committee, and then to Senate Finance Committee at that point. There is also an opioid overdose reduction pilot program for the community paramedics. And we do have, as I said, appropriations. The one piece of appropriation that I just added on in Senator Kiffmeyer's committee was the $2 million per year ongoing general fund dollars for violent crime enforcement team grants with a priority for Greater Minnesota. And the reason for that stipulation, and that's found on page, it's the last page actually of the bill, page 25, line 9, is because, well, number one, there's 21 VSET programs throughout the state, the violent crime enforcement teams. There's actually 16 counties that do not participate in the high intensity drug trafficking area, the HIDA program. And the VSET teams have been consistent in their funding since 2011 at $4.3 million. So this is very, very important to include the law enforcement piece into this bill. Minnesota was a 49th state to finally receive grants from this federal program, the HIDA program. They've been at it for about 3 years now. Hennepin, Dakota, Ramsey, Washington, and Anoka County are all involved in that. I heard this morning Olmsted has got a grant proposal in, St. Cloud, and also Duluth, all very worthy areas that need to have some assistance from this federal program. It's the rural areas that do not receive funding from HIDA at all. So that is the purpose of this $2 million per year for these outstate programs, to help them with boots on the ground, more law enforcement, or to their undercover drug agents, whatever they need, because we have seen this tremendous influx of synthetic fentanyl, the heroin, the opiates, methamphetamine is huge. There's a 700% increase on methamphetamine seizures just this year in the state. So I think, a direct appropriation in this area is worthy. And as you know, as Senate Finance Chair, I'm going to stand by this. I think this is really important.
Does that conclude your comments?
Yes, sir.
All right. Is there anyone in the audience who wishes to speak for or against this bill as far as the jurisdictional areas that we have in our committee?
Where is that clinical? Professional clinical.
We'll open it up for questions and discussion.
Right here.
Senator Pappas.
Thank you, Mr. Chairman. I'm glad Senator Rosen brought that up because that was my question. And Senator Rosen and Senator Limmer, I just have more of a technical question. Is this $4 million to be part of Senator Limmer's omnibus funding bill and part of his target, or is the finance chair moving this kind of off our budget?
Senator
Mr. Chair,
Rosen.
thank you, Mr. Chair. Senator Pappas, that has not been discussed as far as where it's going to land. And I have no problem putting it into Senator Limmer's budget area at all. But I am committed, no, Senator Latz is going no, but I am committed to making sure that we can get some money out.
Senator Pappas.
Well, Mr. Chairman, we're just laughing because I imagine his budget's going to be rather limited, and maybe we all would rather see that you just carry it separately in the Finance Committee.
Senator Rosen, any more
Remains to be
comment?
seen, Mr. Chair. Thank you. And Mr. Chair, I did
I'm
find
curious,
that.
too.
Yeah. I did find that professional clinical judgment. I am sorry, members, that was at the tail end of the bill when I first started. It's on page 17, line 22, if you have questions about prescribing and going forward.
Senator Rosen, on that point, is there a definition of what professional clinical judgment is?
I don't really, Mr. Chair, I don't have a definition. I could bring up Dave Renner from MMA. Perhaps he could say, but I would assume, and perhaps you want a professional.
He was standing up. I don't know if he was trying
their
to go
scope-
to the back door or to the front table.
Yeah, that's right. In their scope of practice, Mr. Chair, I would assume that their professional judgment.
Mr. Renner.
Mr. Chair, members, Dave Renner with the Minnesota Medical Association. I don't have a good answer for you other than the fact that the language that you see on 17.22 is current language that is being just moved from what was already in law in 1718. So this has been in the books for about 3 years, related specifically to oral and refractive surgery. What Senator Rosen and Senator Eaton are doing is expanding this to all prescribing now, so they're just restating that language to apply to all. So my attempt to answer your question is clinical judgment is defined as kind of the standard of care. And this would be a situation that would be determined by the Board of Medical Practice if there was a complaint raised.
Mr. Renner, the term professional clinic judgment, is that a term of art that may be found in other areas of state statute?
Mr. Chair, it is a term of art. Whether it is used in other statute, I can't answer that. It is something that I think most physicians, most practitioners know is this is my professional clinical judgment. But whether that's used elsewhere in statute, I can't tell you.
Any other questions, Senator Ralph?
Thank you, Mr. Chair. Just as a follow-up on Senator Pappas's question about the budget issue, am I assuming that your concept is that the fees that you collect, that 20 million, that $4 million would come out of that, or is this supposed to be just a general fund? All right. Thank you, Mr. Chair. Thank you,
Senator Rosen.
Thank you, Mr. Chair. And Senator Ralph, right, the 20 million, half of that would be for treatment modalities, different ones. And the other 20 million for that whole placement, the 4 million, 2 million per year would be out of the general fund. And we'll straighten that out once we get to finance.
Senator Ingebrigtsen.
Thank you, Mr. Chair. To that point, is this going to be an ongoing $2 million for law enforcement? Is it going to be an ongoing appropriation?
Mr. Chair
Senator Rosen.
Senator Ingebrigtsen, I was planning on it being ongoing, and I don't see that it really says that it's ongoing. It just says for 2020 and 2021.
Mm-hmm.
So
Ms.
perhaps,
Turner?
Mr. Turner.
Mr. Chairman, members, if the bill doesn't specifically state that it's a one-time appropriation, it's assumed that it's ongoing.
It's Mr. Chair?
Senator Ingebrigtsen.
That's an assumption that it's an ongoing appropriation until...
Right, but at
Mr. Turner.
Mr. Chairman, Senator Ingebrigtsen, at a later date, it can be made a one-time appropriation, but usually if it's a one-time appropriation, it's specifically stated.
So Mr.
Senator
Chair, to the point earlier, then this would actually probably best belong in your committee? Being it's ongoing, I'm
It
just-
would be a part of our jurisdiction.
Sure, certainly.
Senator Ritson.
Follow up if I could. Thank you, Mr. Chair. And Senator, would you take me through the mechanics of how a patient has just had surgery and the doctor's about to write the prescription? Does that doctor then have to go into that system to find out if there has been some abuse at all previous? Would that be good information? Would it be, I mean, obviously the person needs it for that particular diagnosis, but there also could be somebody that, you know, that has a history of obtaining opioid elsewhere. Is that going to be required at all, or has that been talked about?
Senator Rosen.
Thank you, Mr. Chair. And Senator Ingebrigtsen, as I perceive it, is if there is a surgery, the doctor can prescribe. But under his professional clinical judgment, if he feels there is a reason to go into the PDMP, he certainly can. But surgery is an exception to it, and that is on page 20. Lines 23 and also lines 2020, number 5 and number 6. So those are the exceptions to having to use it, but under the professional clinical judgment of the doctor, if he suspects some abuse, then he certainly can go in. But it's not mandated
Okay.
at that point.
Senator Ingebrigtsen.
So follow up. Thank you, Senator, for that. And so should, under his professional judgment, decide to check, and there was a very clear track of abuse, a clear track of obtaining opioids, maybe even up into the surgery, how would that be handled under this bill?
Senator Rosen.
Yeah. Thank you, Mr. Chair. And perhaps, we should probably get a professional, because I would assume they would want to get some help for this person. Mr. Renner?
Mr. Renner, welcome back.
Chair and members are using the term professional loosely. So let me try to give you, first of all, as Senator Rosen and others have said, the prescription monitoring program is a tool that has been a great tool for prescribers. As a patient comes up, especially a patient for which you don't have a relationship, they're coming in complaining about back pain or something else, this is a tool to be able to determine, has that patient been elsewhere and been doctor shopping? And it has been a tool that most physicians who use it really like it, except for, as Senator Rosen said, it has been a somewhat clunky tool that has been a challenge to somehow integrate. So what I think Senator Rosen in this bill tries to do is to say, we want to encourage practitioners, prescribers, to use this in those situations where it makes the most sense to use it, where we want to address that issue of doctor shopping. So the exceptions here are situations like you have an ongoing relationship with that patient, you know that patient, you know where they've been. Recently, after a significant surgery, you know there will be some short-term need for pain relief, so you don't have to check it there. Saying all of that, however, if a physician still believes that a patient is potentially abusing or diverting, they can always check the PMP and they can always determine. Once they determine that they see a patient who has been elsewhere and has been potentially using, generally what happens, my understanding is, then there is a conversation. And the physician can say, I don't feel comfortable writing this prescription, or they'll have some conversation with them to try to determine why they need the drugs and how it's being used. I hope that answers.
Thank you, Mr. Chair. Thank you. I think it has.
Senator Ingebrigtsen.
But if they run up against that, where does that patient go then for their pain relief, I guess, is what I'm wondering.
Mr. Chair and Senator Ingebrigtsen, that's a very good question. And one of the concerns that has been raised prior to this legislation going forward is what we don't want is the prescriber to say, sorry, I'm not going to prescribe it. And if the patient then goes out, and what we're seeing is most of the overdoses we're seeing are now coming in the area of heroin and fentanyl because people are now buying it on the street. What I think the purpose of this bill overall is to try to say we need more resources to get into treatment and to education to both patients and prescribers, but the treatment side is really critical because what we're seeing is people are now addicted. They're going to need to try to find these drugs somewhere else. we need to get treatment and get them services.
Any other questions or discussion? Senator Dietzig.
Thank you, Mr. Chair. Thank you, both Senator Rosen and Senator Eaton, for bringing this forward. I know this has been you've put a lot of work into this, so I appreciate that. I have two quick questions, and one of them might be already in here. So on page 20, you have all these exceptions to the mandatory data check, but is there any, in either this bill or already in current law, anything relating to enforcement or consequences if somebody violates these?
Sarah Rosen.
Mr. Chair, and thank you, Senator Disick, and thank you for the acknowledgement. This bill is a work in progress. We have continued to work on this and will continue to work on this, but we do not have anything in the bill addressing that.
Okay. I have a follow-up.
Senator Dietzig.
That's just something to consider.
Mr. Chair,
Sarah
actually, Mr. Renner mentioned that there could be some grounds for, well, Mr. Renner.
Mr. Renner.
I'll defer to him.
Mr. Chair and Senator, there is no penalties in this bill. There's no new criminal or civil penalties. But if it turns out that a physician is not doing what is said here, it would potentially be a grounds for discipline by the Board of Medical Practice. If a complaint is filed that you're not following the law, so there is that potential action by the board.
Senator Dietzig.
Thank you. I say that because I have heard horror stories of, and I don't know if they were actually happening here, but I've heard horror stories in other places where there were pill mills, where certain doctors were just writing prescriptions left and right. Then my other follow-up question is on the priority on funding in the non-metro teams on line 2512. So like in the angel investment tax credit, they talk about 50% should be going to the metro, or 60% of the funding should be going to non-metro, and then after a certain date, it kind of opens up. Are you looking at that, or is the money just going to go to public safety, and then they're just going to do the grants and then just kind of monitor it to see if there's extra money that it's going somewhere and not just disappearing? Because I'm assuming that this is welcome money to law enforcement.
Yes.
Sarah Rosen.
Thank you, Mr. Chair. So, Senator Dietzig, basically, you'd like to have the can I assume you'd like to have the language a little more clear about consequences of where the dollars are going, and if it's geographically dispersed? Better?
Senator Dietzig.
Mr. Chair, I was just wondering if you all had thought about that, just to be a little more specific, or if you've given guidelines, or you might on purpose want it to be just kind of broad. I don't know, I'm just checking.
Senator Rosen.
Thank you, Mr. Chair. And Senator Dietzig, I think I was thinking a little more broad to allow the Commissioner of Public Safety to help build out, as it says, the capacity of small communities that do not receive the HIDA money and will never receive the HIDA money, because there isn't really that much, but it is more grants are coming in for that pot of federal money coming from the Office of Drug Control Policy. So I guess I was trying to allow the Commissioner the ability to put it in the areas where he sees fit.
Senator Dietzig.
Thank you, Mr. Chair. One other option, just to, and I'm saying this because I don't want money sitting there and then we find out, 2 years or 4 years from now it's not being accessed. And so just for your consideration, another thing would be to, and I hate to provide more work for them, but literally say, it'd be good to know that, 20 communities asked for the money, 50 communities asked for the money, or only 5 communities asked for the money. So I don't know if a report literally from BCA or whomever, Commissioner of Public Safety, just saying how many, I think it's good to know how many communities are out there are looking for this money, so you kind of know what's the unmet need, what's the interest, and then you can kind of tweak that based on that need. If no one's accessing it, we can figure out, well, why are they not, and is the grant too hard, or what issues do they have to make it more flexible? Just a thought.
Senator Rosen.
Thank you, Mr. Chair. And Senator Dietzig, that's a wonderful idea, a welcomed amendment, and I will work with staff to make sure we get that right. I'll have to go on probably at unless we do it now, or I can put it on Senator Abler's committee too. And maybe perhaps just check with you when I get the language. Mr. Chair?
One moment, Senator Rosen. Mr. Backus, were you following that last discussion? I'm assuming you would be the appropriate counsel on this one. Is that something that we could amend now?
Mr. Chair, members, if you wanted to put a reporting requirement in, it would be line 25.16 after the period. By February 1st of each year, the Commissioner shall report to the chairs and ranking minority members of the Senate and House of Representatives committees and divisions having jurisdiction over criminal justice policy and funding on the distribution of grants and other money under this paragraph.
Senator Dietz?
I think the distribution is helpful. Also, if that includes the number of people that apply, because I think we also would like to see what the need is or what the requests are. I'm just.
Senator Rosen, while counsel is preparing an amendment, do you have a comment on this?
I would just like
Or
to say
Senator
that I
Reed?
support this because we forgot to do this on the naloxone funding a couple years ago, and we had to personally go out and try and figure out where it went and how much was purchased, and this is much easier.
All right. Accountability is a good thing.
Mr. Chair?
Senator Rosen?
I am very happy for the help on that amendment, and I welcome that amendment. And I also have two other amendments
All right.
when we're ready.
Why don't we consider one of your amendments now that you'd like to have introduced? Which one would you want to start with?
Thank you, Mr. Chair. I have the A18 amendment.
All right. Is A18, it'll be distributed, so why don't we just pause a little bit and wait for the amendment to be passed out. As we pass it out, Senator Rosen, would you explain your amendment?
Thank you, Mr. Chair and members. The A18 is the recommendations from the State Government Committee that we are in, and is actually from Senator Ress offer this, and I welcome this too. So lines 1.2 through 1.9 provides for one of the legislators from each body to be from the metro area, and we found that to be important. Lines 1.10 to 1.11 clarifies that the commissioner must balance geodiversity of the members appointed by the commissioner. Lines 12 through 13 prevents members who have a conflict of interest from participating in this discussion. They were already precluded from voting. And this it actually is probably a little farther than what most conflict of interests are, but there's a large amount of money that's in play here. And lines 14 through 18 changes the due date for the report to the 31st of January instead of the 1st, because we didn't want to ruin anyone's Christmas vacation.
Senator Rosen, was this subject discussed in the State Government Committee?
Mr. Chair, yes, it was, and we agreed. We discussed it, fairly well. There was a few other suggestions she had, such as background checks on the appointees for the advisory council. No, so this was the area that we could all agree on.
Okay, and there was a general consensus that this was the right thing to do by the State Government Committee,
Mr. Chair,
other than
yes.
just discussion.
Yes. Yes.
All right. The committees or the amendments before us, is there any discussion about the amendment? Senator Latz.
Mr. Chairman, did I just hear Senator Rosen say they're going to be doing background checks on appointees to the advisory council?
She said Well, I'll let Senator Rosen explain herself.
Mr. Chair, Senator Latz, no, that was one of the recommendations Senator Rest made that I said, no, we're not going to be doing that, no.
Okay. Because they don't pose any risk to public safety by being there?
I would suggest no comment, Senator Rosen.
Staying out of this one.
Is there any further discussion on this amendment? Senator Ingebrigtsen moves the A19 Amendment. All those in favor say aye. Aye. Opposed? The amendment is adopted. Senator Rosen, did you have another amendment?
Thank you, Mr. Chair. And the A19 amendment is before you. I'm not sure if you have it, and I will defer to Senator Eaton.
All right. We're going to wait until it gets distributed. Sarah Eaton, would you explain the amendment?
Thank you, Mr. Chair. This amendment essentially adds a member who is in, who has an opioid addiction and is in recovery, and removes one of the members who is suffering from a chronic disease that requires pain management. In the last committee, we added 2 of those, and so we're adding one each side of the coin, I guess. One who's using opioids appropriately and one who had a problem with them.
And could you just tell us why this would be important to have this individual on the panel?
I think someone, thank you, Mr. Chair, I think someone who has had the experience of lived the problems that the opioid crisis has caused would be a very effective voice on this committee and would know where some of that best way to direct some of the funds.
All right. Was this particular amendment, was it discussed in the HHS Health and Human Service Committee at all?
No, Mr. Chair.
Okay. Senator Rosen,
Mr. Chair.
do we have any idea of whether they would be in favor of such a concept or not?
Mr. Chair, if you go to page 8, line 30, you will see, and page 9, line 3, excuse me, no, page 9, line 3, that was added in state government, those 2 new members, because of the discussion in Senator Benson's Health and Human Services Committee. We heard testimony from people who suffer extremely severe pain, chronic pain, and there was a fear that their pain relief would be taken away from them. But as I clearly stated, with the professional clinical judgment and all the other exceptions to the PDMP, the ability, some guidelines as far as how much you can prescribe, but still under professional clinical judgment of the physician, I think it's important to make sure that everybody understands that their drugs or their pain can be handled. You need to handle acute versus of chronically different in the way you handle that. So this was the result of that testimony in HHS.
All right. Is there any further discussion on the A19 Amendment? Senator Ingebrigtsen.
Thank you, Mr. Chair, and thank you, Senator, for bringing this forward. I wholeheartedly agree. Somebody who's been there is going to have a good or better idea as to when it comes to abuse. My only question would be is when you have addicts that are recovering, there has to be some kind of it seems to me, some kind of a time lapse. Did you put any thought into that? Just out of treatment, or a year out of treatment, or 2 years out of treatment? I know this is a horrible addiction, and the possibility of relapse is my concern. I think you know where I'm going with that question, the possibility of relapse and how soon of a person declares that they're recovered would be eligible for this program.
Thank you.
Sir, could you identify yourself for the record?
Randy Anderson. I'm a licensed alcohol and drug counselor for the state of Minnesota and also a person in long-term recovery. And I spoke to Chris about this, Senator Eaton, about this amendment due to the fact that I also thought it'd be good to have both sides of the coin represented. So I'm just going to go by what DHS currently does. So in order to get my license, I have to show that I have had 2 years of incident-free sobriety. I think that's a good standard. If you wanted to adopt some kind of language around it, that would be a good recommendation because we already do that for me to be a licensed alcohol and drug counselor.
And Mr. Chair.
Senator Rosen.
Thank you, Mr. Chair and Senator Ingebrigtsen. The whole issue of aftercare and recovery is part of what the advisory council will be looking on. This is an area where it's just exploding as far as what works. The medication-assisted therapy works, the MAT program. We have the ECHO program at St. Gabriel's in Little Falls and also HCMC, and they are doing ITV workshops. I think I heard almost 100 people 1 week were on that, listening to how to provide treatment with Suboxone. And it's the recovery piece, the aftercare, the ongoing aftercare is another huge piece, just as much as prevention and public awareness is at the forefront. Do we have the answer for? No, we don't have the answers for it yet, I don't think.
Senator Ingebrigtsen, did that answer your question?
Mr. Chair, it did. The testifier said that there was a time lapse there that would have to be or should be addressed. My only fear of this, just saying, okay, I'm a recovering opioid addicted person. I don't want it to fail. You know, I don't want that person to fail. I don't want the program to fail because I'm not saying the program would fail. I'm just saying the person should have some time once they're out of their recovery program. So I'm good with whatever you suggest. I'm not saying 2 years is the answer. A year was certainly. How do you track that? I guess. Doesn't have to be changed because I'm bringing it up, Senator. I just think it might be something you may want to consider moving forward.
Mr. Chair.
Senator Rosen.
Thank you, Mr. Chair. And Senator Ingebrigtsen, we will be working on that, and I appreciate that. If you don't mind, just further discussions with the community and going forward, I'd appreciate that. Like I said, this has several more stops.
Senator Rosen, I had a little different twist on Senator Ingebrigtsen's inquiry. The line says one public member who's a Minnesota resident and who is in opioid addiction recovery. Is there a difference between a person that's in their first week of addiction recovery program or a year? Should it be someone that's maybe seasoned in that recovery program? And I don't want to get too deep into this because this is really beginning to stray out of our jurisdiction area. Sir, would you identify yourself for the record again?
Thank you, Mr. Chair. Randy Anderson, licensed alcohol and drug counselor for the state of Minnesota. So I would say yes. The easy answer to that question is yes. The opioids, there's often a long or significant withdrawal period. And so a person can be in recovery and still be suffering some symptoms of their use. And so we want to make sure that they're well past, I would guess, because their brain isn't functioning correctly yet, especially the cognitive portion. We know with addiction that the prefrontal cortex, not to get too scientific, but the prefrontal cortex doesn't operate correctly while under the influence. And so we want to make sure that that cognitive ability is restored to a certain level. It's for each person, of course, it's different. There's no way to know that for each individual. But yes, I would say there's a significant difference between someone a week in recovery from it versus a year in recovery from it. And one other thing I could add is so peer recovery specialists now only require 1 year of significant free problems. They word it a little differently probably than that, where they show that they've had no issues in a year in their first year of their recovery. So there's a little difference from peer recovery specialist to, like for me, for a licensed alcohol and drug counselor. But a year is the minimum there, and it's 2 years for me. So I hope that answers the question.
Sir Rosen, like I said before, I think we're beginning to stray out of our jurisdictional area. I'm going to give it to the committee. If the committee believes that this is an amendment that should be passed, it will eventually, this bill, if passed, would eventually go to the Human Service Reform Committee for a little added focus on this particular amendment. And I'll leave it up to the committee if they want to entertain this amendment. And so Senator Ingebrigtsen moves the A19 amendment. If there's further discussion or not, hearing none, all those in favor say aye. Aye. Opposed? The amendment is adopted. Is there any other discussion regarding this bill or any further amendment? Oh, yes, there's an oral amendment that council was creating on behalf of Senator Dietzig. Mr. Backus.
Yes, Mr. Chair. On page 25, line 16, after the period, insert, by February 1st of each year, the Commissioner shall report to the chairs and ranking minority members of the Senate and House of Representatives committees and divisions having jurisdiction over criminal justice policy and funding on the distribution of grants, outreach, assistance, and support under this paragraph. The report must include information on the total number of requests made for grants, outreach, assistance, and support, where these requests originated, and the amount of money awarded for each successful request, period.
Senator Dietzig. Yes, Senator Dietzig, could you repeat that? Does everyone understand the amendment? I think they do. Senator Dietzig moves the oral amendment as presented by council. All those in favor say aye. Aye. Opposed? The amendment is adopted. Any further discussion on this bill? Senator Latz.
Mr. Chair, I was just going to note that this is one of the fine examples of bills that go through multiple committees and ends up stronger because of the process that we put it through here in the Senate. So I commend Senator Rosen for the work and Senator Eaton for the work on the bill.
Thank you, Senator Latz. Senator Rel.
I do have one other question. This deals with the language on 4.24 to 4.27 on the data that is being used and its purpose. On line 4.25, it says the board may use the data reported under 152.126, subdivision 4, to determine which manufacturers meets the requirement under paragraph A. And that is basically, as I understand it, where they sit in the fee schedule. Is that correct? What other data would they be using? You say may use the data. What other data, or are we using multiple sources? I'm a little not quite sure what's going on there.
Senator Rosen.
Thank you, Mr. Chair, and thank you, Senator Ralph. I am going to defer to Dr. Cody Weiberg from the Board of Pharmacy on this, and he can.
Dr. Weiberg, would you identify yourself for the record?
Mr. Chair, members of the committee, I'm Dr. Cody Weiberg. I'm the Executive Director of the Minnesota Board of Pharmacy. So the bill actually calls for us to collect data from manufacturers and wholesalers that we currently actually don't collect. And that is going to be the primary data set that we use to determine what who's subject to the higher fees. What the language I think you're referencing allows us to do is also to use the prescription drug monitoring program data that we collect now as sort of a reality check. And so we may or may not need to use that, but at least if we want to use that data to sort of compare what the wholesalers and manufacturers are reporting to us with the data we have, it might, again, like I said, serve as a reality check. If a particular manufacturer says, well, you know, we only did 1,000 units, we could look at the PMP data and say, well, so prescribers and pharmacists in the state actually dispense 10,000 units. So how can we work through this discrepancy?
Sir Ralph.
Well, this raises another question, and I don't want to get into the weeds, but you use the term unit. do we have a standard definition of unit? Because I'm wondering how that is the PMP versus the data that's collected from the manufacturers. How is that going to compare?
Dr. Weiberg.
Mr. Chair, Senator Ralph, units, it's not defined in the bill. Maybe that's because as I've assisted the senators and some representatives on drafting these bills, I'm still thinking as a pharmacist and not just entirely a bureaucrat. And so for healthcare professionals, units are what the patient takes. It's a capsule, it's a tablet, it's a patch. If it's a liquid preparation, it's going to be a milliliter of liquid would be a particular unit. That's how billing works in the pharmacy world. When a pharmacist fills a prescription in bills, they're submitting 30 tablets or 480 milliliters for a pint. So in our world, that's what unit means, and that's what we're going to be looking for.
So that,
Senator Ralph.
Thank you, Mr. Chair. So, Doctor, the amount of drug contained within the unit could vary?
Dr. Weiberg.
Mr. Chair, Senator Ralph, yes, it could. So, for example, one particular drug might have 20 milligrams of that drug in it. That's one particular tablet. Another tablet might have 30 milligrams. And it, frankly, is even a bit more complicated than that, in that when you talk about opiates, 10 milligrams of morphine is not exactly equivalent to 10 milligrams of oxycodone. There's differences in potency as well. That was original approach for the bill that we're kind of moved away from that, and we're just basing it just on units. It's a much more simple process to do this way.
So, Mr. Chair.
Sir Ralph, the line of questioning that you're proposing is beginning to go way outside of our jurisdiction.
That's exactly what I was getting to.
We still have another bill.
But I'd like to pursue the inquiry, but at this point, this may be in Human Services where we would pursue that.
All right, thank you. Senator Hall.
Thank you, Mr. Chair. Quick question. Is there or has there been federal funding that we could use for this versus state funding?
Senator Rosen.
Thank you. Mr. Chair and Senator Hall, there absolutely has been federal funding that has come down, and it is, I can grab the name of it if you'd like, but we've received approximately $17 million from the feds and 8 million, 8.2 and I believe 8.7 million per year. And that DHS has done a very good job at making sure that the programs that are up and running, especially the mat therapy and the ECHO programs, a lot has gone to the Native American tribes because they've been hit disproportionately. And they've done a very good job at making sure that that money is getting out, but we need to do more.
Thank you.
Any further discussion? Is there anyone in the audience who wishes to speak for or against this bill? Hearing none, Senator Ingebrigtsen moves. Senate File 751 as amended be recommended to pass.
Mr. Chair, can I just say something? Just real briefly. I want to thank you very much.
Rosen.
This bill is better because of this committee. It's always scary coming in front of you, but it and your members, but it is a better bill because of this stop. So I do appreciate the work.
Yeah, it hasn't passed yet, Senator.
Well, that's true.
Thanks.
That's fine.
Senator Ingebrigtsen moves Senate File 751 be recommended to pass and be moved to the Human Service Reform Committee. All those in favor say aye. Aye. Opposed? The motion is adopted. Thank you, Senator Rosen and Senator Eden.
Thank you, Mr.
Thank
Chair.
you.
Thank you, members. Really appreciate it.
We'll now move on to Senate File 766, Senator Ingebrigtsen.
Thank you for that information. All right. Is he coming up?
If we need him,
Okay.
we need some expertise
Sure.
at some point.
Senator Ingebrigtsen, Senate File 766.
Thank you, Mr. Chair.
Would you explain your bill?
Thank you, Mr. Chair and members. Mr. Chair and members, Senate File 766 contains the same changes to the DWI laws that were made in last year's.
Pardon me, Senator Ingebrigtsen. Would those making conversation in the back of the room please bring it outside? Please proceed, Senator Ingebrigtsen.
Should I be scared too? Thank you, Mr. Chair. I'll start over. Senate File 766 contains the same changes to the DWI laws that were made last year in last year's vetoed omnibus supplemental budget bill, which was at that time called Senate File number 3656. So, members, this is not the first time this has been here. This is something that you're familiar with. I'll just give you a quick overview, and then I'm going to turn it over to my testifier if I can. The primary purpose of Senate File 766 is to expand the scope and use of ignition interlock for DWI offenders by requiring that all second DWI offenders within 10 years or third DWI in a lifetime will not be relicensed until they have completed a term in the ignition interlock program of either 1 or 2 years, depending upon the blood alcohol content and the level of the offense. The bill also recognizes an offense committed outside the state of Minnesota that is in conformity with a Minnesota felony DWI, excludes non-alcoholic related DWIs from the Minnesota Ignition Interlock program, and grants those offenders a limited license to drive, and requires the ignition interlock manufacturers pay the reasonable costs of equipment failures. So, members, I'm going to let my testifier, who's here today, I believe he testified last year quite eloquently on this, take you through the bill, and if there's any questions, we'll both stand for questions.
Mr. Innes, would you identify yourself for the record?
Chairman, members of the committee, my name is Mr. Innes. My name is Ward Innes, and I'm here on behalf of Smart Start, who's a Minnesota-based ignition interlock company. First and foremost, I want to thank this committee and the chairman for last year's work on the DWI front. I think the final product that was included in the supplementary budget omnibus bill was a good final product, and that's why we've replicated it here today, and it's in House or Senate File 766. I can walk through the 6 sections of the bill if you would like, but I know you have Ken Backus's very well-respected summary in front of you. I think he does a great job articulating the different provisions. You know, I think what got the most discussion in this committee last year was Section 2 of the bill. And Section 2 of the bill really takes an important step in Minnesota's ignition interlock law to say anybody who is a repeat offender needs to complete a mandatory ignition interlock program of either 1 or 2 years, depending on their alcohol level content, unless they fall into a narrow exception that's included in this bill. We talked at length about that narrow exception. If you can certify that you do not own or lease a vehicle, or have not transferred a vehicle to a family member in order to kind of avoid the consequences of being a repeat offender, then you would be exempt from the program. So that's kind of the cornerstone, I think, of last year's work. I do think one thing I was really surprised about when I first started working on this issue back in 2018 was that Minnesota has kind of lagged behind the rest of the country as far as the utilization of ignition interlock for repeat offenders. It's worth probably noting that as we sit here today, 30 states in the District of Columbia have what we call all offender laws. So anybody who gets convicted of a DWI offense is required to go on an ignition interlock program for a duration of time. And that is kind of what has been the holy grail for MAD. MAD has really led the charge to pass an all offenders bill in every state in the country. Minnesota, as we sit here today, has a law which doesn't require a mandatory ignition interlock program until you have 3 offenses in 10 years or 4 in a lifetime. And what this bill does is just take that one increment down and say, if you're a repeat offender and you've had 2 offenses in 10 years or 3 in a lifetime, you're going to be required to go into the ignition interlock program prior to getting your driver's privileges fully reinstated. You have to complete that program. So this is an important, I think, incremental step. I think it will undoubtedly make our roads safer. The literature, the peer-reviewed literature that shows the effectiveness, the efficacy of ignition interlock programs is really impressive. Recidivism rates, for example, are 4 times higher for those who do not enter an ignition interlock program than they are for those who enter an ignition interlock program. We've heard there's been very strong evidence that entering an ignition interlock program also helps with recovery. So people are in a sobriety recovery program, having an ignition interlock program, being part of that program is a helpful prompt, I think, and a reminder when they're in recovery. So I do think this is an important step forward in Minnesota. I hope you guys, once again, will include this in your DWI omnibus bill. I'll be happy to try to answer any questions you may have.
All right. Thank you. Is there any questions on this bill? Senator Johnson.
Thank you, Mr. Chair. Just a quick question, maybe kind of a scenario here, but I've got a good friend who had some trouble, lost his license, was out for a while. It's been about 5 years. He's in school and he's doing this. Would he be required then, even though it's been 5 years, to participate then in this program? Let's say he's had five of these DWI arrests. Would he be required still if it's been 5 years since his last incident?
If this law were to
Mr. Innes.
Yes, Chairman, Senator Johnson, the short answer is yes. If this law was to become law, the requirement would be you would have to enter an ignition interlock program at some point for a certain duration of time. And the way the bill is currently drafted, it's 1 or 2 years, depending on your alcohol level. At some point, you'd have to enter the ignition interlock. You couldn't wait out the program anymore if you were a multiple offender. Under current law, right now, if you have 1 or 2 offenses, you can just wait out the waiting period and have your driver's privileges fully reinstated without ever going into the ignition interlock program. The problem we have right now in current law is that only about 14.5% of the people voluntarily enter the ignition interlock program. So what they're doing for that period of time is they're telling us they're waiting it out and they're not driving. But the reality is they're not waiting it out for 1 or 2 years. We know, based on MAT statistics, that 75% of them are actually driving illegally during that waiting period. So that's one of the challenges we have with the program. We want to push participation in the program for those who are repeat offenders. It's worth noting also, and our statistic probably worth noting, is that 60% of the folks who get a first-time DWI never reoffend. So there may be a public policy argument for requiring that group of people also to go in the ignition interlock program, but it's not nearly as compelling as it is for second-time offenders, because then they're much more likely also to commit a third offense as well. So the short answer to that is you can't wait it out for any period of time. You'd be required, if you were a multiple DWI offender. So if it was a first-time offense, you could just wait it out still.
Senator Johnson, I'm going to have counsel expand on this a little bit. Mr. Backus?
Mr. Chair, members, yes, what Mr. Innes said is true prospectively. However, if you're talking about someone who actually maybe currently doesn't have a license or, 5 years ago, as you said, the effective date would make it prospective. So I think in your case, it wouldn't affect him. It would affect people in the future.
Senator Johnson.
Mr. Chair, Mr. Backus, I think, and I'm just using that as an example for what happens to somebody in that same situation prospectively now. Are they going to be, the cost of these programs is significant too. So I know one of the issues that they had, this friend of mine had was, they're going to school, they're trying to straighten out their lives, his life, and now the cost of getting that ignition interlock system is significant. So for him, he couldn't do both, do the interlock system, go to school, and do all that stuff. So it really pushed him back into a corner. So I was just hoping to hear that there was some capacity, some exemptions that somebody in that situation might be able to avoid, having to put that in their car. But under this proposal, there's not.
Chairman, Senator Johnson, as Mr. Backus said, prospectively, if this was to become the law of Minnesota, there would not be a safe harbor to wait that out without entering an ignition interlock program if you were a multiple offender. So you'd have to have more than one offense on your record.
All right. Any further discussion? Senator Latz.
Mr. Chairman, we've had so many discussions about DWIs and ignition interlocks in the last several years. I'm having trouble recalling exactly how I approached this particular wrinkle in the proposal in the past. I'm concerned about the same thing Senator Johnson is about the cost. It'll probably cost someone well over $1,000 a year, probably $1,500 for a year of ignition interlock. You know, for someone who's earning $120,000 a year, that's probably not a big deal. But for someone who's earning $31,000, you know, which is, well, it's what legislators used to earn per year, but it's also the average salary for an incoming teacher or police officer. That's a pretty significant, you know, cost of living impact. So I'm a bit concerned about that aspect of this without some kind of a safe harbor. And I'm trying to remember if in the past, if the language has always looked the same as this, or whether we had some safe harbor affidavit provisions where someone could certify under penalty of perjury that they hadn't driven in the last year. So I guess I'm interested in hearing a little more discussion about that aspect of it. And I'd also like to verify that the length of the revocations that are in here in these provisions are not any changes from current law, so that the length of the ignition interlock is dovetailing with the length of revocation, and those are not any longer than they used to be. Currently.
Mr. Backus, could you answer that question?
Mr. Chair and members, as to the last question, yes, it's the same period as in current law for these offenders, the second and 10, the third overall. And to answer your original question, you know, there is safe harbor language in Section 2. It appears from 2.9 to 2.14. And that is the exact same language that passed the Senate and the House last year and was vetoed in the omnibus bill. And I believe, maybe the witness could clarify, I believe it was the same language as also left our committee last year as well.
Chairman, Senator Latz, Mr. Backus, that is correct. And I believe also, maybe with a slight variation, it was the same language that passed the full Senate in 2017 when Senator Latz chaired this committee. It was very comparable to that. It gave a safe harbor for someone who did not own or lease a vehicle or have access to a vehicle. It was an issue, I think, that was originally broached by Senator Champion at one point.
Senator Latz?
Yeah. Thank you. Mr. Innes, do you recall whether the language that Senator Champion was looking at, is this the same language that Senator Champion was comfortable with as well?
It is.
Mr. Innes.
Chairman, Senator Latz, we were very mindful to try to color within the lines and duplicate what the Senate passed in 2017. I think that passed nearly unanimously in the full body. So we did include that same language that Senator Champion came forward with. I think there's one maybe variation in that language, and it was something that was adopted by the House initially. And it says if you got to certify that you haven't passed ownership of the vehicle to a family member and have implied consent to drive the vehicle. And that's included in the bill in front of you. I don't think that was part of the Senator Champion amendment in 2017. Yeah.
So, Mr. Chairman.
Senator Latz.
So there, under this language, then there would not be an option of simply riding out the revocation period or reinstating without ignition interlock and just going through the old process, if you will. We're just getting a limited license after a waiting period.
Chairman, Senator Latz, that is correct. The key point of that Section 2 is to make sure people who have multiple offenses cannot any longer just wait out the waiting period. It's been a real challenging thing for the program, I think. That's been a real challenging thing to enhance public safety. And as I said earlier, the trend nationally is very much to go all offenders. People who get a DWI have to enter an ignition interlock program. Even with the passage of this legislation, we'd be very much middle of the pack as far as the utilization of ignition interlock in Minnesota.
Mr. Chairman,
Senator Latz.
We've pretty clearly, up to this point, rejected the all-offender concept, applying mandatory ignition interlock to first-timers. I also had another question on sections 3 to 5, but I don't want to cut the discussion on Section 2, so maybe.
Any further discussion on Section 2? Hearing none. Senator Latz, do you want to proceed?
Yeah, could we
And
ask?
Senator Latz, I wanted everyone to know on the committee, we will lay this bill over for possible inclusion in the DWI omnibus bill later this year. So you can still raise your questions now if you wish.
No, thank you. Mr. Chairman, could we get a brief description then of the impact of Sections 3 to 5 here and how they compare to current law?
Mr. Backus?
Mr. Chair and members, I think looking at Sections 3 to 5, they are tied together. I think it's somewhat easier to look at them starting with Section 5 and then looking at Sections 3 and 4. Section 5 basically, under current law, a non-alcohol related DWI is included in the Ignition Interlock program. So Section 5 takes non-alcohol DWIs out of the Ignition Interlock program. Then Section 3 amends the limited license law to allow those offenders to get limited licenses. And then Section 4 specifies the hard revocation period for those offenders. So if it's a first-time offense, they'll still have the 15-day hard revocation, but beginning on line 7.4 to 7.17, there's either a 90 or 180-day hard revocation period, depending on whether they submitted to testing and failed or refused testing. And those two hard revocation periods go back to the law prior to 2011, I think it was, to kind of mimic what it used to be for those offenders.
Senator Latz.
Thank you. Mr. Chairman, Mr. Backus, those 90 and 180 days, do they represent what portion of the total length of revocation do those represent?
Mr. Backus.
Mr. Chair, I believe the 90 days would be compared to a year, and the 180 days would be compared to 2 years.
So, Mr. Chairman, I mean, I know that at least as of now, the technology does not have an instant interlock program that addresses use of substances other than alcohol. Part of the theory in the past, I believe, has been that there's a lot of co-occurrence of use of substances. For someone who's got an addiction, it's not unusual for them to have alcohol is one of the substances they use, as well as other controlled substances that might have been the subject of the particular DWI. I don't have any evidence base that I can cite for that, but I think that's been part of the theory anyway. I'm a bit concerned that if you go back to 90 days or 180 days hard revocations, especially in greater Minnesota, but even so in the metro area, without a fully built-out mass transit system, that will definitely cause people to lose their jobs and will probably cause a lot more driving after withdrawals so they can try to keep their jobs. I mean, can anyone on this committee, even with if they had repeat DWIs, imagine trying to go 3 months without having any driving privileges or any option for driving privileges and still be able to get to and from where they need to get on a daily basis just to keep a job, let alone 6 months. You know, and here we've got options, expensive as they can be, of taxis, Ubers, Lyft, other ride-sharing programs, the bus system, and in some areas, light rail transit. You get out to greater Minnesota, and that's just not an option for you. If you live in the next town over, either you're begging, borrowing, paying a neighbor or a friend or a family member to drive you to and from work every day, or you just can't get to work. And so that's been part of the problem, and that doesn't help anyone deal with the substance abuse problem either. It probably makes it harder. So, I mean, there's no perfect solution in this situation, and someday I suppose the technology will catch up where they can detect, you know, use of Schedule 1 and 2 controlled substances through the breath. I think technology probably does exist in some areas now to do that, but it's not part of an ignition interlock device program. But until that technology catches up, I think we at least have to factor in whether it makes sense to go back to those old days, or whether we at least get a modicum of public safety protection with the ignition interlock program in there, even if the underlying driving while impaired crime was for use of a Schedule 1 or 2 controlled substance. And I should note that those can happen just with the presence of a controlled substance in your body, too. I mean, you can be impaired by anything, and if the state can prove that you're impaired by it, you're convicted. But if you have even the presence of a Schedule 1 or 2, regardless of how it affected you physically, that's a violation of the DWI statute. That could result in one of these license consequences here in Section 4. So I guess before I would be willing to support this, I think I'd want to know more about the statistical underpinnings of this. How many DWIs would be affected by this? How many situations do we have where they've installed the ignition interlock to protect against alcohol use, but for some reason they've been stopped and convicted of subsequent controlled substance-related DWI, meaning the interlock didn't protect the public from that particular person's driving conduct? I guess I'd be interested in more of that information before making a decision on this.
In trying to get to your question, is there anyone from DPS that might be in the audience that could answer some of the statistical underpinning on this proposal?
And Chairman, if I may, just maybe to your point, Senator Latz, we've grappled with the same issue. I think the genesis for that provision in last year's omnibus bill was Senator Limmer's counterpart in the House, and his position was that non-alcohol related DUIs should be exempt from the ignition interlock program, and that it was his decision that he thought reinstating those hard waiting periods was the right way to go. I think DPS shares some of your concerns about that. I think the theory that you expounded about people who have committed a DUI with a non-alcohol related substance probably also may be co-abusing or using alcohol as well. So there may be some value to going in the ignition interlock program. So I think some of those issues, and DPS was kind enough to meet with us last week, and they did flag that as a potential issue, those sections that you just talked about, Senator.
Okay.
Mr. Chair.
Welcome to the committee. Would you identify yourself for the record?
Jane Landwehr with the Office of Traffic Safety.
Your last name again?
Landwehr.
Landwehr.
Did
you understand the concern of Senator Latz?
Well, the first question of how many second time or how many drivers would be affected by that, I don't have the number here, but that is a number that we can get as the state.
All right.
I believe the Office of Traffic Safety and myself agree with Senator Latz. The longer waiting period times for limited license is only going to encourage illegal driving. We've seen that over and over again. So I don't agree with that part, or the waiting periods for limited license.
Senator Latz, did you have any further question at this time?
Mr. Chairman, I don't know if OTS has this or someone else might have information on co-occurrence of abuse of substances behind the wheel, if there are any statistics available about subsequent offenses for controlled substance convictions and whether they were alcohol-related or non-alcohol-related subsequent offenses, that would also be helpful.
Ms. Landwehr, did you understand that
Yes,
inquiry?
Mr. Chair, Senator, we
and could you speak into the microphone?
The Office of Traffic Safety does have a grant that we do with the BCA. What we're doing is testing old urine specimens, and this is just urine taken from DWIs. After a year, they dispose of them. We're doing a grant where we've been testing those urine specimens, and it is, I believe, 38 to 42% of those samples also tested positive for drugs. These are samples where once they detected the alcohol, they stopped testing for anything, and it went on to the court case. But this is after the fact. It was relatively high, yes.
Any further discussion?
Well, Mr. Chairman,
Senator Latz.
Because you're going to hold this over, I'm not quite sure how you
Right.
want to approach these. I'm prepared right now to make a motion to delete sections 3 to 5, unless I get convinced down the road that there's really a solid evidence-based reason to move forward with it. But I don't know if the chairman wants to entertain that kind of approach, or if you want to have us deal with those when the bill comes up in an
Senator-
omnibus context. It'd be harder to discuss the whole thing when you come on with an omnibus bill.
Yeah, I know it is, but Senator Latz, your inquiry wanted to seek out specific information from the department. We don't have that in front of us right now. I would suggest, since we're going to lay it over, let's gather the information from DPS, and then once we have it, we can understand it better. You can present your amendment if you so choose, with us having a little bit more background on it, if you would.
If the chairman decides to include sections 3 to 5 in the omnibus bill.
That's correct. All right.
Thank you, Mr. Chairman.
Senator Ingebrigtsen.
Thank you, Mr. Chair, and Senator Latz, just know that I'd be more than happy to work with you on that when the information comes and moving forward, so.
All right. Any further discussion regarding this bill? Hearing none, we will lay Senate File 766 over for possible inclusion in a DWI omnibus bill. There's no further business before this committee. We stand adjourned.